Prash Sanders, and I'm talking today about atrial ischemia as a determinant of atrial fibrillation after myocardial infarction. My institution is the Royal Adelaide Hospital and the University of Adelaide in Australia. I have some disclosures for this talk, and this is presented here. Atrial fibrillation commonly complicates a number of substrates that occur in the clinical setting, and myocardial infarction is no exception. We can see in this slide here that the incidence of PCI has increased as a primary treatment for myocardial infarction. But despite this, while there are variable reports, there seems to be an overall maintenance of the incidence of atrial fibrillation that occurs acutely after myocardial infarction, this ranging somewhere between 5 and 20%. Indeed, even during the follow-up afterwards, there's a high recurrence of atrial fibrillation in the order of 22%. Atrial fibrillation occurring in this setting has a number of effects, and here we have a slide from my group. This is Dr. Dennis Lau's work, and it demonstrates the occurrence of atrial fibrillation and the composite outcome as a result of this. And if you have no arrhythmia, you can see the outcome that occurs, and much worse if you have previous atrial fibrillation. Presumably this is because it's slightly older population. But indeed, if you have new onset atrial fibrillation during a myocardial infarction, your outcome is significantly worse than either of these groups. Atrial fibrillation occurring in this setting certainly has an adverse effect on morbidity and mortality, and this occurs both in hospital and out of hospital in the first 6 to 12 months following the event. Now, how atrial fibrillation occurs in the setting of myocardial infarction has not been well studied so far, but there's certainly many culprits that we could turn to for this. Atrial ischemia is but one of these. This is elegant work from the, Dr. Nattel's group, where they studied a dog model of myocardial infarction. Indeed, it was an atrial infarction model where they ligated an atrial branch, and they looked at the inducibility of atrial fibrillation. Indeed, if you have an atrial infarction, these animals were more prone to atrial fibrillation. And shown in this slide is their findings in terms of conduction abnormalities that occur in a time span from the control situation over through to half an hour, 3 hours, and then 5 hours. And progressively there was more conduction abnormalities, which gave them a greater propensity to the development of atrial fibrillation. One's got to consider that while this is a controlled situation of atrial ischemia in a dog model, in the human situation there are a number of factors, including a diastolic dysfunction, ventricular infarction, and stretch of the atrial chamber, together with the autonomic changes that occur during a myocardial infarction, in addition to atrial ischemia, that could promote atrial fibrillation in this setting. I want to present some brief findings from our group. This is work from Dr. Muyad Al-Asadi that was presented here at the Heart Rhythm 2010 meeting, and we really looked at what was happening in the clinical setting as to why patients with myocardial infarction would develop atrial fibrillation. This is from a prospectively collected cohort of patients with acute coronary syndrome presenting to our institution. We evaluated the characteristics associated with the development of atrial fibrillation. We have 3,200 patients over a 4-year period who were seen at the institution with an acute coronary syndrome. Of these patients, we had 149 who had AF develop during the first week after their myocardial infarction. We then deciphered this group to really exclude patients who've had a previous history of atrial fibrillation, who've had valvular heart disease or other causes that are well known to be established causes of atrial fibrillation, such as hypertrophy, diastolic dysfunction, and coronary artery bypass grafting. And we also selected those who had angiograms done within 48 hours of their presentation, and also transthoracic echoes, so that we could evaluate the hemodynamic and also angiographic views as to whether there was something that was predictive for the development of atrial fibrillation in this clinical cohort. These 42 patients that we ended up with were matched on an age, sex and left ventricular ejection fraction basis to compare these groups, so we can determine the characteristics that predicted atrial fibrillation. Now, we had to use a definition of what could be atrial ischemia in the absence of functional imaging to determine atrial ischemia. We use coronary artery anatomy as a definition of atrial ischemia, and shown here are the branches that one may expect. On the left, the normal coronary artery on the right side, with the atrial branches, both the sinoatrial and AV nodal branches that occur from this level. We also have a right atrial branch that can occur. And we defined ischemia as that being critical ischemia proximal to this or at the level of the atrial branches. An example of this is shown on the right of the screen. Similarly, in the left coronary system, we have coming off the circumflex artery, the left atrial branch that in this example is shown in the uncompromised atrial branch on the left, and then with an occlusion of the proximal circumflex or the atrial branch, we define this as a compromised atrial branch on the coronary system. So if we look at this group of patients, 42 matched patients, they're pretty well matched for most of their characteristics in terms of age, gender, body surface area, their risk factors for coronary artery disease, hypertension, diabetes, hyperlipidemia, and their use of other medications, and also previous coronary events. So well-matched groups, so we can make a comparison as to the impact of atrial ischemia. Echocardiography was performed in all of these patients during the week in sinus rhythm, and to give us an idea of how this may impact the development of atrial fibrillation. Indeed, importantly, the left ventricular function is within normal limits. That is, the ejection fraction, the end diastolic dimension, and also the presence of left ventricular hypertrophy were matched within these two groups. However, when we then look at an indicator of diastolic dysfunction with the E to E prime ratio and also of mitral emptying, we find that this is different in patients who have atrial fibrillation compared to matched controls. Similarly, the left atrial area and the left atrial volume index is increased in patients with atrial fibrillation rather than those without atrial fibrillation post-myocardial infarction. When we look at the coronary anatomy as to what could be contributing to the development of atrial fibrillation, certainly an inferior myocardial infarction was much more likely to be associated with the development of atrial fibrillation. ST segment elevation myocardial infarction, interestingly, occurred less in this group of patients with myocardial infarction, with atrial fibrillation. The primary angioplasty was used less, and presumably this goes hand in hand with the previous comment on ST segment changes. There was more left main disease, more triple vessel disease, although this did not reach significance. Certainly more right coronary artery lesions, left circumflex, and importantly, more disease in the right coronary atrial branch disease, and also left circumflex atrial branch disease was significantly more in the patients who presented with atrial fibrillation. If we look at the univariate predictors of atrial fibrillation in this model, we have these factors that stand out: left main disease, E to E prime, left atrial volume index, and both the right atrial and left atrial branches from the coronary anatomy being compromised were factors that on univariate analysis were associated with atrial fibrillation. However, when we analyze this on a multivariate analysis, introducing all of the factors that have been shown on univariate analysis to be predictive of atrial fibrillation, the standout here is right coronary atrial branch disease was highly predictive of the development of atrial fibrillation, together with the left atrial volume index. Patients, in keeping with other studies, patients with atrial fibrillation in their first week had a much higher complication rate. And these are depicted in this example here, particularly in terms of bleeding or early ventricular fibrillation in this setting, remembering that these patients had controlled for left ventricular function. The major adverse effects were 40% in the patients who had atrial fibrillation compared to only 12% in those without atrial fibrillation, suggesting that atrial ischemia and the changes that go with it, development of atrial fibrillation is associated with a major adverse outcome after coronary artery disease. So, ladies and gentlemen, I'm going to conclude by suggesting that atrial ischemia, as evident by atrial branch disease, is an important determinant for the development of AF after myocardial infarction. We certainly can only, in human studies, get a limited amount of information, as we have in this study, showing coronary anatomy is compromised in these patients. In addition, left atrial volume index seems to have an important role, and this is consistent across all substrates that predispose to atrial fibrillation. These findings are independent of age, gender, pressure load, and also LV systolic function. Thank you for your attention.